Good morning, everyone. We have not yet started. I was just giving it 5 minutes. So we plan to start at 11:05. Just to let you know, you want your mics are disabled to enable us to control whoever is speaking and who's not. But if you can hear me, you can just put a thumbs up just to confirm. Okay. As rules, we shall keep questions as the presenter is presenting. You will just note down any questions you have. And at the end of the session, we shall have a Q&A. You'll just be able to raise your hand and you'll be given access to your mic and you'll be able to unmute and speak. It's 11:05. We'll just introduce you to our facilitator for today and the topic. So our topic today is understanding occupational health. This is one of the areas I think that mostly ignored because it comes with the long-term well-being of employees. So it's not something that you identify at early stages, but it's important for the long-term well-being of employees and sustainability of workplaces. The reason for this topic is to give a deeper insight on the topic, occupational health, and how we can work around it as health and safety professionals to promote not just physical, but also the mental being of the people we work with in our places. Our facilitator today is Dr. Okulo Robert Obuku. He is an occupational health doctor that works with Work Health Consult Limited. He'll be able to introduce himself further and what he does, but he has experience in occupational safety, which is specifically his field of and he'll be able to unpack for us the concepts of occupational health and highlight its relevance in today's work environment and share any actionable insights. Dr. Okulo, over to you.
Good morning, team. I hope you're all listening to me well. I'm Dr. Okulo, as Elizabeth has introduced me. I'm Dr. Okulo Robert Obuku. I'm an occupational health physician. I've been in occupational health for the past 15 years, dealing with very many industries, ranging from service industry, transport, mining, oil and gas. And I'm happy to be here to share information concerning occupational health in Uganda. So I would like to share my slide. So occupational health, as the WHO and the ILO, that is World Health Organization, and the International Labour Organization define it, it is a promotion and maintenance of the highest degree of physical, mental, and social well-being of workers in all occupation. And this entails the physical aspects ranging from movement, the mental aspects ranging from the way staff relate with one another, and social well-being relating to finances and relationships within the workplace, and who has considered occupational services to be responsible for what we call total worker health. That means a holistic approach to health of workers, as earlier described. physical, mental, and social well-being. And if you look at it, it is talking of his or her family, meaning that the worker will not be well, healthy, if he or she has a sick child or he or she has a sick wife, and therefore they also have to be catered in a total worker health perspective. So one of the things that we get, there is what we call organizational health. It has pillars. Organizational health has 4 key pillars, and in various organizations, they decide to choose which pillars are of importance. So the first pillar is occupational health, which has a few of the following: risk assessments, occupational hygiene, occupational safety, fitness for work programs, and other programs that we'll discuss in the next slides. Then we have primary health care. Now, primary health care, you find on-site primary health care. That depends on the organization. You have seen certain companies having clinics, fully furnished clinics for staff to access medication. That means for primary health care. That means acute and chronic illnesses. Then we have off-site primary health care, where staff go to access medication for their health, especially through the health insurance, which we are going to discuss in the other pillar. Then we have specialized care, meaning more of emergency, specialized care more with emergency services, and also consultancy services like physicians, cardiologists coming to visit the site, the workplace, and physiotherapists coming to give treatment. Curative is within the bracket where there is treating of acute illnesses like cough and flu, malaria. Rehabilitation care, mainly physiotherapy and other rehabilitation services like what we call work hardening and work conditioning. Emergency care, having emergency services, that means presence of an ambulance within the workplace. Health education, that means providing health educational sessions, what we call the health talks to staff on how to work healthy, be healthy in a holistic manner. Then chronic disease control, that is within the program of primary health care, trying to control staff's chronic diseases, for example, hypertension, diabetes, and others. Then we have the employee well-being. This is what we call wellness services, where we do wellness medical checkups. That is for staff who, for example, above 40 years, organizations bring service providers to do checkups for them, like pap smear for ladies. Male above 40 years, they do PSA, prostate-specific antigen, to check for risk. Others do hepatitis B to screen hepatitis B and vaccinate staff. So those are some of the wellness checkups. Then employee assistance program, this is mainly with mental health, having a fully fledged mental health program which can be inbound or outbound, meaning that it can be solely orchestrated by the company, or it can be orchestrated by the company but with support from other service providers. Travel medicine looks at mainly travel of employees to high-risk areas of epidemics, pandemics, and other non-regional diseases. Then employee benefits. This is the benefits that employees take. So different organizations decide on what to do. Medical insurance is one of them. Not all organizations provide medical insurance, but majority of them provide medical insurance as a benefit. Then we have group personal accident. This is what is part of the what we call the Workers' Compensation Act, Workers' Compensation Act Cap 225, where all organizations or companies are required by law to have compensation. So the insurers have made it much better to include certain benefits in what we call the group personal accident. Then we have severance pay, which is within the Employment Act, and then sick leave, paternity leave, and maternity leave. Those are benefits within the Act. Now, occupational health has physical, engaging in healthy behavior, mental, building resilience as regards to work demands, the mental work demands. Social is more about fostering good relationship with the bosses, the heads of departments, the supervisors, and fellow colleagues at work. Financial is obviously having appropriate salaries or finances in regards to the work being done. And lastly, occupational is looking at satisfaction of work and the workplace tasks, and if somebody is satisfied with the work he's doing and he feels valued in the work that he or she is doing. So occupational health has 8 key pillars. We have what we call clinical occupational medicine. We have laws and regulations in occupational health. We have work fitness, disability, and rehabilitation. We have occupational toxicology, hazard recognition, evaluation and control, surveillance and disease prevention, health and human performance, and lastly, occupational health audits. So I'll be going through each to give you an insight into what each is. So occupational medicine is a branch of medicine which is mainly multidisciplinary, meaning that we do clinical treatment, diagnosing, and treating of employees or workers with occupational or work-related injuries, illnesses, and diseases. And it's multidisciplinary, meaning that we involve not only occupational physicians, but we involve other general physicians, specialized physicians like pulmonologists. Those are doctors for the lungs. We involve also neurophysicians, rheumatologists. We also involve orthopedic surgeons and general surgeons, depending on the condition. So we treat injuries, for example, a fracture of a radius bone just on the right arm after a fall. That one is treated by an orthopedic surgeon. We obviously have to call the orthopedic surgeon on board to be able to either do a closed reduction or an open reduction and internal fixation. That means to make sure that the bones come together. Then illness is fatigue, example, fatigue from high workload. That is usually, illness is usually a subjective from the staff that they feel fatigue. So staff usually come and they say, oh, I'm tired. I usually get tired, fatigued because of the workload. So we treat that and give them remedies to be able to overcome that. And then diseases, the known diseases related to work, like, for example, occupational asthma. So the laws and regulations, we have 2 main ones that I'm going to talk about. The main is Article 5 of ILO, Occupational Service Convention number 161, and recommendation of number 171, states the functions of occupational health. And one is identifying and assess risks. These are mainly health hazards in the workplaces. The second is programs, to develop programs to improve work practices within our workplaces. The third is analyzing occupational accidents and diseases, which obviously health and safety professionals have done a lot of this, but mainly to the injuries. But diseases take time, so people don't do that much follow-up. However, it is important that all health and safety professionals get to understand that the commonest occupational or work-related disease in Uganda is back disease. So we need to be able to do an analysis of staff who complain of recurrent back pain, what we call recurrent mechanical back pain, which is progressive and ends up causing them challenges in their work. And majority of them, by the way, do a lot of litigation as regards to back pain, the chronic back pain. Then the last is there is surveillance of workers' health in relation to work. Surveillance, we are going to discuss more about it. Let me not talk about it much here. We are going to discuss about it in the next slides. Then we have immunizations in relation to biological hazards. For example, we had challenges with the policies. Most organizations did not have vaccination stroke immunization policies. And this caused a big challenge when COVID came in and staff refused to be immunized against COVID-19. So it is one of the key roles of occupational health according to ILO and WHO. Then campaigns for protection of workers' health. These are campaigns to protect workers' health, trying to make sure that we promote a healthy and a safe workplace through the ensuring of the hierarchy of controls and what we call exposure to health hazards in the workplace. Then vocational rehabilitation. This is not being done at all in Uganda, in my experience. Vocational rehabilitation talks about mainly looking at staff who is
No,
unfit.
doctor,
Yes,
can you move slides? We are unable to see the slides.
hey, I moved already a slide.
Oh, okay. We're still on laws and regulations.
Laws, yes, this is the laws and regulations, the second slide of laws and regulations. I'm on vocational rehabilitation. You are seeing that?
No, we are still seeing the one for
The first one.
serving.
Yeah, so the second one, are you seeing it?
Yes, now it is.
Pardon?
Yes, we can
Are you
see
seeing
it.
the one of immunization?
Yes, thank you.
Are you seeing the one of immunization?
Doctor, I was able to see it, but now you've moved back to the previous one.
What have you seen now? What are you seeing now on the screen?
And we are still on the surveillance of workers' health in relation to work.
This
Just
one.
clicking. Still on the first slide. Okay, it has moved. It's okay.
Has moved, eh? It has moved?
Yes,
Okay.
it has.
Okay, fine. So I was talking about immunization in relation to biological hazards. I was saying most organizations do not have immunization or vaccination policies. And this caused a lot of problems, challenges to implement the immunization of employees, especially during epidemics or pandemics. For example, during the COVID-19, staff refused to be immunized against COVID-19, and this caused a lot of issues at the workplace. Then we have campaigns for protecting workers' health. These are mainly to ensure that safety at work is up to date, ensuring that we implement the hierarchy of controls and be able to protect our workers from health hazards. Then we have vocational rehabilitation, which I said is not being done at all in Uganda. And this is mainly when a staff is unable to meet what we call the health requirements of the job, then he or she can be reskilled to be able to do another job, another role. For example, if somebody was doing a lot of manual handling but has some knowledge of computer, they can reskill them with additional skills in computer, and they can work in the front desk, they can work in records, depending. But this is not this is not being done in majority of the organizations. Then we have collaborating with ministries, health ministries in public health programs. We have organizations that have incorporate programs within their organizational health, especially their primary health care. And that is, for example, HIV, AIDS treatment, access to drugs of HIV. Most organizations that I've been able to work with, they have a HIV program where staff and their dependents who are HIV positive are able to access the services from the company clinic. That means CD4 count being collected, viral loads being collected from there, and their refills of their ARVs being collected there. So these are the mandates that are within the ILO. So in Uganda, our Occupational Safety and Health Act of Uganda, 2006, has certain sections that talk of occupational health. One is Section 18, which talks about the employer is supposed to monitor and control release of dangerous substances into the environment. Those are mainly dusts, fumes, vapors, chemical vapors. They must control that. Then 19 talks about provision of protective gear, and that is what we call PPEs within our hierarchy of controls. Section 20 talks of employer to provide alternative suitable employment, what we call reasonable accommodation. This is here and there on a case-by-case basis. Some organizations have been able to do that. Others have found it big challenge to do it. In my experience, the human resources have not been fully able to implement this because of a lot of logistic challenges, a lot of challenges during with the person recruited, and challenges with implementing what you call vocational rehabilitation. This one is not being done very well. But other organizations have been able to try and do it, but not fully. Section 21 talks of supervising health of workers, employer to supervise the health of workers. And this, in very many organizations, this is not being done. And I will discuss more about this. Supervising the health of workers is more of doing what we call a medical surveillance program, doing a pre-employment checkup before the person starts job, doing an annual checkup for those who are at high risk, and doing an exit medical occupational checkup for staff who are exiting and who are at high risk. The last is Section 22, which talks of medical records. Now, most human resource organizations don't have medical records, and it is very challenging for us as occupational health doctors to defend them when it comes to injuries and diseases at the workplace. And this is one of the key issues that I promote to make sure that the human resources have medical records of employees. The slides are moving?
Yes, Dr. Ria.
Okay. Work fitness. This is the capability of a potential worker to meet what we call the physical and mental health requirements. Any job within a workplace has physical and mental requirements, what we call health requirements for the role. For example, I've just given an example of a driver. A driver must be mental, the mental state must be normal, meaning that the person should be should not have a history of, for example, history of epilepsy, because we know epilepsy is not it comes at any time. It is what we call, it's like a short circuit of transmission of electrical impulses in the brain. So we expect all drivers to be normal because the epileptic attack comes at any time. And once it does, then there are challenges. You don't know what would happen. So we make sure that drivers have a normal mental state. The driver also should be able to have a normal eye vision. They should be able to see six meters, within 6 meters, or the best eye, that is 6/6. Then the third is they should be able to use both their upper and lower limbs with flexibility. Dexterity is flexibility. There should not be any challenges. However, some of these, like now, the dexterity, we have seen we have seen persons who drive vehicles with one arm, who have no other arm, and they are driving with one arm. But that is because they are driving themselves, but they are not driving other persons in the workplace. Anyone who is driving a person in the workplace and comes to us, this is what we look at. Then a driver, for example, needs to have controlled chronic diseases. For example, high blood pressure should be controlled if they have it and they are taking medication. And if they have diabetes, that is high blood sugar levels, they should be controlled. If they are not controlled, then that means they are not meeting the physical health requirements for the role of a driver. So this is what work fitness is. So work disability is the incapability of a potential worker to meet the physical and mental health requirements for the role. For example, if a driver, his blood pressure is above 180/100, then that means the truck driver is unfit to meet that, temporarily unfit. So here what we usually do, we tell them to take medication for 2 weeks until the pressure comes down to closer to normal. Then we are able to allow them to continue to drive, but when they are taking medication, and we follow them up every 6 months. The mental incapability, I've talked about epileptics. Epileptics are excluded. They are unfit to operate any mobile equipment, including driving. So we don't allow them to be operators of any mobile equipment because we are not sure of their mental state and when the epileptic attack will come. So this is disability. So solutions usually, as I said, treat the disability what can meet the job's health requirements. That's what we have done, we have discussed about in high blood pressure. And then redeploy, we can redeploy a staff. That means recommend to human resources to give the staff another role, to a less demanding role, what we call reasonable accommodation. But this is a case-by-case basis and it depends on the organization. We have had challenges because to implement this, because of a lot of technicalities dealing with numbers and dealing with how a staff came in, the staff was employed for a particular job, and they did the interview for that job, and you find that they do not have skills. So vocational rehabilitation is not applicable. The organization cannot be able to do that. So they end up telling you, can we do an early health retirement? So we end up having to retire the person early, depending on the condition that they are in. But the fallacy, the challenge that we have in Uganda is most people think of retirement on medical grounds, and retirement on medical grounds is not correct, because when somebody is retired on medical grounds, let's say 28-year-old is retired on medical grounds, that means they are moribund, meaning they are bedridden, or meaning that they cannot do any other job. Majority of people we have seen who have been retired of staff, we have seen who have been retired on medical grounds because of a back problem. Once they have been given money, you see them on borders riding, passing the gate of the organization, and people ask, what was the doctor doing? So we usually we do what we call early ill health retirement, and not retirement on medical grounds. Worker rehabilitation is part of our work where we medically and physically repair staff, injured or diseased workers, to enable them to attain some optimal physical and mental health capabilities and be able to return to the work they were doing, or to be able to return to work and be redeployed to another role. So it involves medical treatment where we involve specialists, other specialists, pulmonologists, as I mentioned, physiotherapists, occupational therapists. Then there are even surgeries, depending, drugs, depending, physiotherapy, work conditioning, work hardening. These are very, very big programs, which also include psychologists and psychiatrists, depending on what it is, and then vocational rehabilitation, which I talked about. This new skills training that is within worker rehabilitation. So we also do what we call worker disability assessment. This is a process of determining the residual physical and or mental capacity of an injured or diseased worker. And it involves determining the level of maximum healing. Now, before you do this, you must make sure that you have exhausted the doctor, the team, the medical team, the occupational and medical teams have exhausted all treatment avenues for that condition. And once that is done, then we will be able to determine the level of maximum healing. Then you determine what we call permanent physical and mental incapacity, and you use the schedules in the Workers' Compensation Act, Cap 225 of Uganda. Unfortunately, the Workers' Compensation Act schedule does not include the current injuries and diseases that we are experiencing in our country, Uganda. The key one is there is no mention of anything dealing with the back problem, back disease, either disc herniation, disc prolapse, the discs have prolapsed or have herniated, or they have bulged. So there is nothing that talks about back. So we incorporate other similar schedules in other countries to be able to provide a percentage of permanent incapacity for any worker who has a back or any other problem. Occupational toxicology is a science of adverse health effects from chemical exposures to workers. And this is quite a very sensitive area in Uganda, in our workplaces, in various occupations. So the determinants mainly are the chemical characteristics. For example, different forms of lead, lead powder. Then we have the route of entry, which we look at. Is it respiratory? Is it skin contact? And then we have what we call exposure limit values, what we call OELs, occupational exposure limits, and the target organ that is damaged, the lungs, the kidney, the bone marrow. That's where these chemicals end up causing challenges, causing problems, causing diseases. So common chemical exposures that we have been able to to work with in the various industries, manufacturing industry mainly, is lead powder and its liquid form also, organic solvents like benzene, toluene, turpentine in painters, organophosphate insecticide that is in agriculture, and the flower industry, malathion and palathion, and then TDI, toluene, diisocyanate, which is used in making of mattresses. Then chromium 6 in cement, which is a non-sensitizer of the skin. Then zinc oxide in metal fumes for welders, silica in cement, stone mining, and stone wax. Then we have chromated copper arsenate, which is a wood preservative for mainly the electrical poles that they use to preserve the wood. So we have what you call two aspects of monitoring that we as occupational doctors do. That is what we call biological monitoring, where we monitor the chemical agent or metabolite in the body. For example, in the body fluids. For example, we take blood sample and we check for lead levels in the blood. Then we have another, what we call biological effect monitoring. Here we look at the biological effect of the chemical. For example, in lead, in organophosphate contact, that means insecticides, we look at there is an enzyme in the red blood cells that is used in transportation of the chemical for transmission of impulses, electrical impulses through one nerve to another. And therefore, we look at what we call the cholinesterase enzyme in the red blood cells. So that's what we monitor to look at the effect. And it gives us a finding on how the exposure and effect is on the person, on the worker. Hazard recognition, this is done by most health and safety professionals. However, our emphasis as occupational health doctors looks at mainly health hazards. And we do this through what we call a human health risk assessment. And we also, in addition to that, we do what we call an occupational risk exposure profile. And in that, we also do what we call capability fitness standards. Now, this capability fitness standard is looking at the health requirements. A person who is operating a computer, for example, must be able to see, to have a normal near vision. So they must be able to read near small letters, must be able to read small letters. So they must be able to read to near vision. So that means that's what we call the capability fitness standard. A person who is operating a machinery and has to stand for a long period of time has to be able to have a normal back spine without any disc herniation, disc prolapse, or disc bulge. So those are what we look at. Occupational risk exposure profile. For every job, we grade the exposure of risk, of the health hazard risk to health, and we provide a profile for each job and look at which one is high risk through the human health risk assessment. So all this leads to what we call a medical or a health surveillance program, which I'm going to discuss more in the next slide. Evaluation. In evaluating our risk to health, we have two matrices and ratings that we use. We use the Malaysian Risk Assessment Model Matrix, and then we use the Malaysian Hazard and Exposure Definition Ratings. These will be more elaborated when we have another session dealing with the human health risk assessment, where we will be able to go through these two in detail, but I'm just giving an overview of what we do. The controls. Our controls, we have specific occupational health controls for high-risk health hazards that we recommend usually in the workplaces. One is that we usually recommend to modify tasks of workers. For example, we find workers using their energy to manual handle, to lift, carry and lower load. So we recommend organizations to purchase load carrying equipment to reduce the exposure of the ergonomic stressors related to manual handling. So restricting worker to specific tasks. So we also recommend usually for certain staff, not to do any manual handling tasks and do other tasks that do not expose them to ergonomic stressors. This is obviously quite challenging, but it's always a negotiation between the supervisor, the HR, and the employee. And then we redeploy physically or mentally incapacitated workers, for example, a loader going to security, which is also quite challenging because of certain human resource, but usually we also have a negotiation with the human resources to give them the benefit of redeploying the staff and being able to make them more productive. Then we have what we call medical surveillance programs. This is a follow-up program, which I'm going to discuss more about it in the next slide. For example, following up staff who use TDI in making mattresses, that is toluene diisocyanate, which is a non-sensitizer and a causer of occupational asthma. Then we do recommend also occupational health trainings. For example, mental health champions training. This is mental health champions are part of the employee assistance program within a workplace and are key in promoting positive mental health in the workplace. Then we have vaccinations or immunizations. For example, hepatitis B, biological hazard hepatitis B in the workplace, and even COVID-19 depending. Safe systems of work, we usually provide what we call method statements or standard operating procedures for staff working in various industries. For example, the service industry, mainly the call center operators. We usually tell them to have rest breaks after 1 hour of using headsets, 5 to 10 minutes or break between, which is sometimes very challenging, but we give them that information and try to help them to work safely. Then we have safe tools and equipment that we recommend, like now, for example, ergonomic chairs. We usually do ergonomic risk assessments and advise organizations to provide ergonomic chairs. And also, for example, call center operators, we usually advise them to provide what we call circumaural headsets. These are headsets that cover the whole ear pinna, that is the whole earlobe, and cut off what you call background noise. And usually they have what we call noise cancellation effect. So medical surveillance, as I told you, is just monitoring of health of workers exposed to high-risk health hazards. And not all health hazards that staff are exposed to are supposed to be in the program. Only those that have of high risk after conducting the human health risk assessment. And you feel that a medical surveillance program is a recommendation that we need to continue following them up, considering that if, for example, our main control is use of masks, let's say organic solvent masks is the only control, which we know is not as effective, it's dependent on the user being able to implement and being able to use them. Then we must do a medical surveillance program to detect early any subclinical findings, signs of an occupational asthma. For example, if it is TDI. So TDI exposure leads to occupational asthma, silica dust leads to silicosis, and lead exposure leads to heavy metal disease. So we in the surveillance program, we have pre-employment medical examinations, what we call entry occupational medical checks that are customized depending on the exposure or on the industry and depending on the role that the person is doing. They are not fit for all occupations. No, they are customized for that role. Then we have the annual or biannual occupational medical checks. For certain moderate risk health hazards, you'll be required to do a biannual medical checkup, occupational medical checkup, or after 3 years, annual occupational medical checkup. But for those that are at high risk, you have to do them annually. Then exit occupational medical checkups are never done in very many organizations. And this has caused a lot of issues with organizations that I work with. They have had to be called to try and defend them in the medical arbitration board as regards to health of workers. And ideally, exit occupational medical checks are very, very important because they help to ascertain any adverse health effect from exposures of employees. Then we have job transfers, occupational medical checkups from one job to another. So this one is done by high-end organizations that are that have a very high-end occupational health program. Not all organizations do this job transfer from one job to another. If you are being relocated, let's say you are being told to let's say let's say you are a welder and you have got issues and you are told, no, from now on you are going to be loading, then that changes. That changes the way. So there are different health requirements. So we need to do a different medical checkup. Occupational disease causality, we as occupational health doctors or physicians, we are called to confirm or to prove the relationship between the health hazard exposure and the adverse health effect that the worker has. So that correlation or relationship is what we are called to prove. And for example, as I've told you, manual handling, that means exposure to ergonomic stressors of bending, awkward postures like lifting, twisting the lower back, bending, and then lifting of weight, load, which is, for example, if it is above 25 kilograms, and then depending on the surface, depending on the frequency. So we are called to do this, to say if somebody has what we call a back disease, let's say disc prolapse, what do you think? Is it the work he was doing? Is it a direct cause? Is it because of a degeneration, age related? What is it? So we are called to do that. And we use a criterion. So we use a criterion which is, we look at 5 things, mainly, is it possible? What we call biological possible. Is it possible? Is it true that if somebody is exposed to a health hazard can lead to this adverse health effect? For example, if somebody comes with an occupational asthma and was being exposed to toluene diisocyanate exposure, then we are sure, because it is known in literature, that this is a sensitizer of the lungs and can cause occupational asthma. So we will be able to say that it is true. There has to be a strong strength of association from literature between the exposure, that is the health hazard, and the outcome. For example, if somebody comes and has hepatocellular carcinoma, HCC, then that is usually synonymous with hepatitis B infection. Then we have another one. There should be a strong relationship between the disease history and exposure. We find stuff not mainly in the temperate areas, not in the tropical areas, temperate areas where there is what we call Legionella pneumonia or pneumoniae, where staff are exposed to Legionella species from the ACs that are not well maintained. Then we have exposure must precede the health outcome. That means somebody can get what we call chromium dermatitis in cement. The loaders of cement, that contact with the cement bag and the cement itself has chromium. And chromium 6 is known to be a skin sensitizer. So once we get that, then we have a relationship that indeed this cement skin contact caused the chromium dermatitis. Lastly, there has to be a linkage. It should be specific. The exposure and the outcome must be specific. They must not be other diseases or what you call confounding factors that relate. And that is, for example, silica. Any person who's exposed to silica, we expect them to be exposed to have silicosis, and there is no other cause of silicosis apart from silica dust. The health and human performance, this one looks at mainly promoting health in the workplace, mainly looking at the productivity of employees or workers. So we do this by, one, providing health information to a worker to make an informed decision. Health information can be personal health and work health. So personal health can be, for example, providing them with knowledge on how to be able to be safe as regards to their sexual health, for example. Then we give education, which provides knowledge on the worker health as regards to how they should safely work, which also has a safety component. As I have mentioned, we usually provide information to call center operators in regards to the amount of volume they should be able to use when they are listening to inbound calls or when they are making outbound calls. Then training, imparting skills on worker health, mainly, for example, economics training, being able to assist the workers to know how to lift better, office workers how to sit in an ergonomic position and be able to make sure their backs and other limbs are in neutral positions, the joints and the muscles. Then supervision, we monitor worker health by doing checkups every year, as I've mentioned in the medical surveillance program. Lastly, occupational health audits. Most health and safety professionals have been able to do the usual health and safety audits. Part of the health and safety audits, there is occupational aspects of occupational health in them, but ours is in detail, whereby we look at the performance of occupational health management systems in organizations, conforming to the ILO, WHO standards, and the OSHA Act of Uganda 2006. So we have areas that we look at which are synonymous with other audits. like organization and management of occupational health in terms of implementation. Who is the contact person? Do they have a lead? Is there a policy, occupational health policy? We have occupational health and safety policies in workplaces. But when you read them, there is no aspect of occupational health. They don't talk about key aspects of occupational health relating to one that we shall, as an organization X, we shall be able to prevent occupational or work-related illnesses, injuries, and diseases. We shall be able to provide medical checkups to staff, and treatment for anyone who gets an injury or illness will be provided, will be given full treatment until recovery. And if they fail, if they have any disability, we shall be able to rehabilitate them. Now, those are key aspects that we don't see in very many occupational health and safety policies. Then we do look at individual health and fitness for work aspects in the whole system. And this looks at, obviously, the medical surveillance program. Was staff checked before they came to work? Are you doing the annual medical checks? Are you doing the exit medical checkups? What did you find out from the checkups? Did you follow up the staff? Did you close their recommendations or not? Assessment of health hazards and risks. This is the human health risk assessment that we look at and see if those high-risk health hazards had recommendations and those recommendations were implemented and closed. Then the control of health risks, that goes hand in hand with what I've just mentioned regarding the assessment of the health hazards and risks. Monitoring of occupational health performance. These are monitoring tools. We look at some of the, mainly the leading and lagging indicators that talk about occupational health. For example, how many staff are physically fit without any medical or occupational disease? How many staff have medical diseases and are controlled? How many staff have non-medical disease, let's say occupational diseases and are controlled? Those are the things we look at. And then obviously we also look at how many trainings staff have done, occupational health trainings that they have done, depending on this. Then we look at trainings and awareness, trainings done to sensitize, educate workers as regards to occupational health. We look at documentation, data integrity, and record keeping. We talked about one of the key aspects, that is Section 22 of our Occupational Health and Safety Act, Cap 225, talks about medical records. So we look at record keeping, if records are being kept. Ideally, in a medical surveillance program, all staff records must be kept and for at least 40 years. Then lastly, we look at the audits, if they had internal audits, and then we look at the audits, previous audits, and then we look at the review, just like all the other audits. Thank you for listening to me.
Thank you, Doctor, for the presentation. We shall be opening up the floor for any questions. As I had mentioned earlier, we shall, if you have a question, you just raise your hand and I'll be able to enable your mic. If I enable, you'll be able to unmute and speak. Yes, Amayeye, your mic is enabled. You can go ahead and submit.
Thank you so much for the presentation. I think after a very long time, this is the first time I've had a presentation on occupational health, and I must say that I've left. I think I've learned a lot. My one main question is: are we going to get the slides for the presentation?
Yes, I'm going to provide the slides for the presentation for everyone.
Yes, for
Thank you so
those
much,
that
for
were
that.
able to register for this webinar, we have your email addresses, so we'll be able to share those with you. Also, we have a YouTube channel as the association where we'll be sharing the whole presentation, so we shall be able to share the link and you'll be able to access it. Yes. Yes, Rockville, your mic is enabled. Rockville or Plot, you can unmute your mic and speak.
Right, thank you so much, presenter, for very detailed presentation. It has been very, very informative and insightful. No doubt a lot of notes have been taken. However, I also have one or two questions to ask. And one of them, what you are just concluding about the policy enforcements. And I'm asking, what mechanisms are in place currently to enforce the OSHA Act of Uganda? Because we see a lot of things happening. There is a lot of waste management, improper waste management or disposal in many of our industries in Uganda. We have so much failure to adhere with the exposure limits in many of these industries. So what mechanisms are in place to enforce this OSHA Act to ensure compliance with ILO recommendations across, let's say, across all these industries at the national level? That's one. The other one of concern is the capacity building, right? What national level initiatives are being implemented to build capacity among stakeholders, especially the regulators, the employers and employees, specifically looking at upholding occupational health standards, right? Those are my two concerns. Thank you.
Doctor, would you like to handle one by one, or we can have all the Q&As and
Let's handle the Q&As at once, and then I can be able to see.
If you've already submitted, please put your hand down. While Ogwang Charles, your mic is enabled, you can go ahead and submit.
Yes, good afternoon. Thank you very much, Dr. Kulu, for your submission. My question is, there are always a lot of activities concerned with the welders. They inhale a lot of fumes, and also those who deal with cement. So from your studies, how long do you think these workers can start falling sick as a result of inhaling these fumes, especially the welders and people who deal with cement fumes? Thank you very much.
Samuel Aloquera, your mic is enabled, just go ahead.
Yes, good afternoon, everyone. Hope I'm audible. Thank you, Doctor, for the presentation. Mine is about supervision of health of workers. As an organization, yes, we've done the onboarding medical checks, the offboarding, and then the annual medical checks. However, in between there is a gap in supervision of health of workers, especially when it comes to reporting of health incidents or ill health. There is a question between the confidentiality of somebody's health, which some people believe, okay, which is considered personal information, as well as revealing some health issues that could be occupational related. Now you find you do not get enough information to monitor people's health because they do not report maybe the illnesses they get, and it becomes hard for you to point out whether you have an occupational issue that is causing it, or maybe it is non-occupational related. That is information you can't get until people surrender it to you willingly. I don't know what mechanism could be there to gather information without necessarily infringing on people's privacy of their health, but while also getting necessary information to rule out any sources being occupational related. Because on the same hand, you'll also have people coming from home with maybe conditions that are existing at home. And when they develop illnesses, they blame it on the work. Or they have issues that they've got at work, but then they refuse to to bring it out, claiming that, no, this is something I got from home, not from work. So what would be the best way of gathering information on health beyond just the annual, the offboarding and the onboarding medical checks? Thank you.
Yeah, I think that was the last question. Let me just check chat. Do we have any? The other questions in chat. What's your guidance on human health risk assessment? What is its relevance on occupational health programs in an organization? Doctor, you can go on and respond to those. I think they're about 6 questions.
Okay, thank you very much, team, for those questions. The first one was asking about the mechanisms in place to implement and enforce the OSHA Act of Uganda in various workplaces. I have been privileged to work with the Ministry of Labor, Gender and Social Development, the OSHA department. And they have had challenges with implementing the OSHA Act, especially in the private sector, manufacturing, transport, mining, etc. And this is because of mainly a cost implication that is within the whole implementation. However, in what I have been able to do is, it is usually a one-on-one situation. It is not an easy one because of majority of the organizations that I have visited have a political hand in them. So what I've been able to do is to discuss mainly with the human resources and try to empower them with the benefits of implementing the OSHA Act standards and other standards. So I've been successful in organizations that have a mother company outside the country, what we call international organizations. Those ones have been able to implement, and also certain local organizations we have been able to push through, but majority of them, especially Chinese-run organizations and Indian-run organizations, have been there, talked, but it is hard, it's tough. So we cannot do it on our own unless we have support from the stakeholders. The key stakeholders are mainly the Ministry of Labor, Gender and Social Development and the government at large. As regards to capacity building, yes, it is a very, very big problem, very big challenge for us in Uganda. For example, we don't have more than, let's say, 10 occupational health physicians in the country. And of those who are very, very active in occupational health, especially in the private sector, are like 2 or 3, because the majority of the others are in the School of Public Health, and they are into academia mainly. So it is a big, big challenge. So what we have done is that we are trying to build our own capacity in terms of levels. Something has already been started. That is, the Makerere University has a master's program in environment and occupational health, which is just starting. So one of our colleagues is there as the lead in occupational health and is trying to churn out. So our main capacity building is for us to be able, as occupational physicians, to be able to attain minimum lecturers requirement, which is a PhD, for them to listen to you, and you can be able to set up a program in the public and private universities so as to churn out staff, students or health and safety professionals who can be able to do something within and can be able to help workplaces to be healthy and safe. The other is about welders. Now, welders and fumes, welders for metal fumes and cement loaders or in the production department with cement dust. Now, the duration is dependent on the person's health, what you call the lung health. The duration is dependent on the person's lung health. However, we should not wait for this, because when you get what we call mental fume fever from zinc oxide inhalation of a loader, of a welder, that is a gone case. There is nothing. They will just tell you there's nothing we can do for you. If somebody has silicosis, it's essentially cancer of the lungs. There is nothing they can do for you. Even if you go, you'll be coughing blood. There is nothing. And you see, when you start coughing blood, the worker starts coughing blood, they will be thinking of TB, then they do HIV test. No one. Because I have one of my experience, there is one person who worked in one of the cement factories prior to safety measures, and the children were taking the father in and out of hospital, and this is what they did: coughing, chronic cough, coughing blood. But they were saying, we can't see anything. They do chest X-rays. They don't know anything about how does silicosis present in a chest X-ray. What are the key issues? So our aim should not be looking at, how long can these people continue inhaling until they get sick? It depends. It can be 2 years, it can be 4 years, it can be 10 years, it can be 20, depending. But once it comes, it is irreversible. Once you get silicosis, once those diseases come, they are irreversible. So we need to make sure that we implement our controls. We make sure our dust bags, our LEVs are working and they are trapping the dust, cement dust, and people are using their protection masks, and the welders are also making sure that they are using their masks, and they are also welding not in confined spaces or in open air for air ventilation. So all in all, I can say the determinant is usually dependent on the person's health. If the person had COVID and is a welder or is into cement dust inhalation and is not using the protection, you expect the person to get issues. He's going to get issues, recurrent cough, cough, cough. I have a gentleman, by the way, who joined the company. One of the companies is a cement factory company. And at that time, they were doing pre-employments, but they were doing pre-employments in a haphazard way. They just do they were not even doing chest x-rays. They were simply checking they were just doing checking using the scope, the stethoscope. And they say, you are fit to work. This gentleman entered within a week, the man was coughing, seriously coughing. By the time they came to discover, they realized the person had a chronic lung disease because he had done CT scans of the lungs. And because he was not truthful during the employment, the plant manager just said, I think you should get out of here. And that's how he lost his job. So we need to make sure that we do not take these things for granted. People come with their illnesses. So we must make sure that we do the checkups well, and we also control health hazards at our workplaces. Supervision of health. There was another question about there's an issue of confidentiality. That one is there. However, my take on this is this. One, the pre-employments, the annual medical checks, and the exit medical checkups must be able to give you, the person who is doing it must be able to give you a report that states that these people have the following illnesses, and must be able to relate these illnesses, whether they are occupational or non-occupational. If you don't have that report, make sure they give it to you, because you must follow up this stuff. This is not just doing, because majority of the things that I've seen is that pre-employments are done and somebody says he's fit with follow-up, or somebody says it's, but they have conditions. These conditions must be followed up and ascertained that indeed they are occupational or non-occupational. The aspect of confidentiality is with the human resources. How? Simply that the doctor who is doing it shares this information with the human resources, and they see how best they can be able to handle, as long as the issue is affecting the health of the worker. I can tell you, as I speak now, I am here working on a case of a gentleman who is saying that his diabetes that he got is because of the work he was doing. You can imagine that. So how are you going to say confidentiality, yet here the person wants to take the company to court that he should be retired on medical grounds or early health retirement because he got the diabetes from work and he cannot work because of his diabetes? So these issues of these issues of saying, oh, confidentiality. No, the confidentiality clause is there. It is very easy. You can handle it between the doctor or the medical personnel who is doing it with the human resources, with actions that can be able to follow up all staff and make sure that their health is known by the people who are in charge. That means the medical personnel and the human resources. The last one is on guidance of human health risk assessment in occupational health programs in the workplace. Yeah, a human health risk assessment is very, very important because it provides you, it provides the organization with a set of high risk health hazards that must be monitored in the medical surveillance program. So you'll have a medical surveillance program. Not everyone, like now people in office, they don't have much risk. People who are working in computers, who have they are prone to back problem, but they are not as highly exposed than persons who are in, for example, welders. Welders are highly exposed to very toxic fumes. Staff who are in production in the packing plant in the cement industry, they are highly exposed to cement dust. Staff who are exposed to chemicals, for example, in manufacturing of mattresses, they are exposed to high levels of toluene, diisocyanate. So those are the ones that you are supposed to monitor every year, because the day they get a problem is the day you will be sued very well as a company. And there is nothing that we can do if you do not have a medical surveillance program, because you have to have information to prove to the medical arbitration board or to the courts, the magistrate court, that indeed you took care, your duty of care was observed, and you made sure that you monitored the health of the workers. So human health risk assessment is very important because it helps you to identify those high health risk hazards and be able to formulate a medical surveillance program, which can be either annually or biannually, but you are monitoring. Thank you very much for listening to me.
Thank you, Doctor. You've been able to handle all the questions that have been submitted. We have a few more in the chat.
Yes.
One on, is there any cause or partnership with UNBS to have proper, genuine PPE for betterment of workers who use this personal protective equipment?
Any other?
Yes, is there any? No, that's the only one.
So yeah, the aspect of PPEs and quality of PPEs, obviously those are dictated by UNBS. But as I told you earlier, this is a front from the different parastatals, different departments of the government. And we in the private sector find it a challenge to enter into it because it's a business for some people. And the quality aspect is UNBS that is supposed to do that. I don't know if there is, I think there should be a department in UNBS that does the quality aspects of PPEs, but the PPEs that we see in downtown, that we look at in downtown, some of them are really of low quality and you wonder how they passed. So it should be a front from SHAU to bring those issues on board that you have mentioned as regards to the quality of PPEs and UNBS, issues dealing with capacity building of health and safety professionals and occupational health physicians, and the implementation and enforcement of the Occupational Health Act. That will be able to help us through SHAU to help be able to push for a change in attitude and policy implementation, and be able to have a buy-in of these organizations to be able to meet the particular standards set.
Thank you, Doctor, for that. Also, to add on the question for capacity building, this is one of the areas, this is where we have this webinar to also support members, HSC professionals, to be able to know, to go into detail of some of these issues from the professionals themselves. This is part of the mandate of the association, and we normally have this once in a while, but we'll be able to push on any information that comes on that we feel is relevant to people. That's why these webinars are open to everyone, because we believe this information should be for everyone. We have a hand up from Domach. Domach, your mic is enabled. Just go ahead and submit. Domach Deng, you can unmute your mic and submit. If you're unable to, you can just type in the chat, then information will be relayed to us. I think if we have no other questions, we encourage you as we close. This webinar was organized by the Safety and Health Association of Uganda. We are a membership body that brings together occupational safety and health professionals in Uganda. And we accept members that are passionate about occupational health and safety. If you need any information on how to join, you can go to our website and also reach out to me. I'll just put my number in that chat. If there is nothing else, I'll just request that we close. Maybe just to give someone opportunity, because I saw people that were thanking Dr. Okulo in the chat. I'll just give an opportunity to Asoka. Asoka, are you able to raise your hand, and I give you opportunity to unmute and give a vote of thanks to our presenter? Your mic is enabled. Just go ahead and submit.
Hello.
Yes,
thank you very much.
audible.
Am I audible? Hello.
Yes, you are. Yes,
thank you
you
very
can
much. My name is Dr. Soka. I'm following you in from Kenya. I think I met one of your members who gave me the link, and I'm very happy. I've learned a lot. I'm trying to compare it with the Occupational Safety Health, Occupational Health Act here and how we do it. But as I said in the chat, the experiences and challenges are the same. Everybody's trying to dodge the law and that kind of stuff. But I'm very happy with Dr. Robert Okulo. It has been very insightful, and it has been very, very good and very, very educative. And I think you are doing well in Uganda. I know, okay, there are all these challenges I see in terms of personnel. The numbers are very low. I think we are a bit higher than that, but we have all these people spread in ministry, departments, and agencies of government and academia. So I think mine is just to thank you very much. I'm really thrilled that I was able to join in, and I'm happy. I'm a public policy and governance expert. Actually, I've been in charge of agriculture policy at the State Department here in Nairobi, and I'm just happy to try to diversify into labor issues. As you said, there are a lot of, I see a lot of occupational health issues in agriculture. We have the same thing here with pesticides and that kind of stuff, which has even gone up to the National Assembly discussions on banned pesticides in Europe and why are they in Kenya. It's quite controversial, but I'm just happy to listen to Dr. Roberts, quite knowledgeable. Congratulations. And let's have a good weekend. Thank you.
Thank you very much. Those that were asking about the certificates, unfortunately, we do not give those at the moment. We shall look into that in the future because of your CPD and evidence for those members. Just to close, thank you all for attending. Have a good afternoon.